Okay, so if it was all about structural changes only present, then our role as a physiotherapist again becomes very limited. Okay, so that is why when it comes to evaluating these individuals and then formulating what type of management you are going to give as a physiotherapist, because then this becomes definitely a surgical intervention. Okay, but not all individuals require a surgery unless it has again led to some neurodeficit. So in that case, we need to find out what is the dynamic component and how is it that the mechanical forces are going to influence these individuals. Okay, so realize that the central canal or even the lateral canal that we have been talking about, where the stenosis has taken place, is going to not be constant, or the dimensions are not going to remain constant in all the positions and postures and movements. This is what I was even talking about when we discussed listhesis before this. Okay, so it has been seen that the further compromise tends to occur when the individual is loaded, okay, in the loading phase. So when there is a lot of compression that is exerted onto the spine, and of course during extension biased activities. Okay, so we may be talking about a person who is walking or being in this vertical position, the upright position, for a longer period of time, which is where the lordosis, which is the natural curve of the lumbar region, is assumed, and that is a position of extension. Okay, and it has been also seen that the opposite is true. So while compression and extension will decrease the space that is available in the central canal as well as in the lateral canal, distraction and flexion are likely to increase them. Okay, so it has been found out that with flexion there is an increase in the area that is available to the spinal cord. Okay, so while the extension decreases by almost a 15%, so you can imagine if the person has got in the neutral position of the spine, that is of lordosis itself, some compromise, further extension is only going to aggravate it. Okay, and that is why most of these individuals tend to remain in a little bit of flexion, because that is a position they have found out to be of lesser symptoms. Okay, this could be simply from the fact that, as we said, the cross sectional area of all these will increase, and the other reason could be the fact that the facets open up in flexion. Okay, so all in all, there is a larger amount of space that is available because of the spinous processes going apart. So the posterior elements are more widely spaced in flexion, and that would allow more space that is available in the flexion position. Okay, so that becomes a dynamic component and this is something that is as a physiotherapist we have to bear in mind, because this is what you're going to utilize when you are planning an exercise therapy for them. Okay, so how is it that these patients present to us? So even if more of the acquired causes could be like PID and so on, still I had clearly mentioned earlier itself. God, one sec. Just give me a second. I'll just find out what is happening with the inverter. Huh? Just a second. In the meanwhile, you can just read through this slide. Okay, I just need to change my position. This point is not working. Just a minute. Huh? Yeah. Okay, sorry. I do not know. Am I on mute or what? No, okay.
No, ma'am.
No, ma'am. We can.
No, yeah, I realize so. So what I was saying was all this is going to be a chronic presentation, and that is why the in the demographic features most of our individuals are going to be elderly individuals. Okay, so if I'm looking at an elderly individual coming with the kind of symptoms that we are going to discuss, the first thing that should come to our minds is canal stenosis rather than the independent causes of PID or of course there could be degeneration